Hi and welcome. I'm Moira Cook and I am District Director of the Health Department office here in Middlebury. We serve all of Addison County through a variety of public health programs, including the WIC program, breastfeeding support. We do disease investigations. We also do things like immunizations, emergency preparedness, and chronic disease prevention. I'm also the convener of the Addison County Committee on Opiate Addiction, and we are a group of human services providers and community members who are really concerned about trying to help prevent addiction and increase access to treatment options for opiate addiction. Today's topic is medication-assisted treatment, and I have the great pleasure of speaking with Dr. Emily Glick, and Emily is with Bristol Internal Medicine, and we're going to talk a bit about her role as a physician at Bristol Internal Medicine and how she got into treating those who are struggling with the disease of opiate addiction. Welcome, Emily. Thanks so much for coming.
Thank you for having me, Maura.
Thanks. So just tell us a little bit about yourself and how you got into medicine, what drew you to become a doctor.
Yeah. So I'm Emily Glick. I'm an internist at Bristol Internal Medicine. I've been a full-fledged practicing internist for approximately 3 years, and I got into medicine basically because I loved science and kind of was a little bookish, but I also wanted to work with people and help people. So it felt like that was a good mix of those two interests.
Great.
So, and I went to University of Vermont for medical school and for residency, and here I am, and I'm in Bristol and loving it.
So what does it mean to be an internist? You know, what's an internal medicine practice?
So an internist does primary care for adults, and so we work with people 18 and over, and we just take care of general primary care needs, whether it be you come in because you've sprained your ankle or you have high blood pressure, you're just in the hospital, if you have diabetes, maybe depression, some forms of, even some milder the psychiatric illnesses, and addiction falls under some of those things that people sometimes come into their primary care office about. They don't know what to do or where to turn. So
great. So, as I said at the beginning, we're focusing on medication-assisted treatment today, and you were the first physician in recent history in Addison County to become certified to provide medication-assisted treatment for those who are struggling with opiate addiction. So, what's involved with becoming certified to provide that kind of treatment, and why you, Emily?
Well, so the certification process is actually, it's not too bad. It's an 8-hour training program. There are a couple different ones that physicians can do. Some of them involve mentorship with people who are already practicing, but the requirement by federal law is 8 hours of training ahead of prescribing. And why me? Well, couple reasons, and the big motivating factor is coming across people who were desperate and basically didn't know where to turn, and were asking for the help. They were aware of medication-assisted treatment with buprenorphine, and requesting that help and that assistance. That they wanted to stop using opioids, in these cases particularly heroin, and they had been unsuccessful. In rehab, they had been unsuccessful in trying to stop on their own, and were aware of other people who had had success with being on buprenorphine, and had made that request, seeing if I could help them. But at that time, I wasn't certified, and there was no formal program in place, and I felt fairly helpless. And one of the people in particular had wound up in the hospital twice, and through whatever fortunate circumstances, they're still. The person is okay, but it was very harrowing to watch, and I just felt that I needed to do something. And prior to med school, I had had a number of experiences. Prior to med school, I worked with the elderly, and I worked doing research, and but I also spent a year working at the Methadone clinic in Burlington. Doing some intake. Doing some drug testing, learning more about that process, and understanding that it was a beneficial it was ultimately beneficial for the people who are struggling with addiction and for the greater community at large. So knowing that it was going to be not only feasible to do this, but also it was going to be most likely a better outcome, rather than pushing that, oh, they should make another go at trying to get off the heroin again.
Right.
So
that's great. Well, it's exciting to have this kind of treatment option in Addison County. Are there other physicians working with you to provide this type of treatment, and do you work with other providers around the state?
Absolutely. So we're very lucky in Vermont. It's a very organized kind of effort. There's a lot of education and standardization of prescribing practices. I'm very fortunate to work with Dr. Lynn Wilkinson and Dr. Will Porter, who have taken this on, trying to address the needs of people struggling with addiction in Addison County in particular. That's our we do end up helping other folks in need, but that's our primary purpose, is to help those folks in our own backyard. And we work with folks around the state, people in the addiction treatment field. There's a really excellent collaborative through Dartmouth. Dr. Ben Nordstrom, very, very helpful. I've worked with Dr. John Brooklyn up north, the Chittenden Clinic, who's been a very helpful mentor to me. But yes, we do aim to, there's special state guidelines, and we work with other doctors in the community. We take care of some of the prescribing of buprenorphine, and we collaborate with them in the care of their patients. So we don't, some patients will have a separate primary care physician and see us for treatment. And then a lot of times I have a lot of my primary care patients, well, let me put it to actually the other way around. A lot of the buprenorphine patients I take care of are also my primary care patients.
Sure.
So I get to address some of the other health needs.
Great.
It's actually a fairly small proportion of my practice. Is probably fewer than a quarter of my time is spent on buprenorphine, and I am still really primarily a general internist but with a special interest in making sure that those with addiction get treatment.
Well, it's great. And about how many folks are you treating at Bristol Internal Medicine?
Between the three of us, we are currently treating 65.
That's great.
65 folks. Oh no, more than that actually. It is. I think it's 80, in the low 80s now actually.
Okay.
Sorry.
And do you have a wait list, and what's that looking like?
Our wait list will tend to vary over time. There have been a couple of times where fentanyl has made an appearance, and there have been more overdoses, and that will sometimes drive up the number. Usually the wait list has been anywhere from, at the low I think was about 40, and at the high I think was close to 100. So there definitely is a desire. Some of those people are looking to transfer for treatment closer to home, but a fair number are people who are really still just newly looking to be on maintenance therapy.
Right. Is there something that folks who are waiting to get into treatment can do? Are there options for them other than calling all the various treatment providers?
Well, there's a couple things available. There's been a waitlist study through UVM through Dr. Stacy Sigman, which is actually a very interesting idea, where people can carry this special device that contains their medication. It's a way of trying to decrease diversion of medication possibly.
Right.
They've looked at that issue, but also just in terms of doing preliminary treatment for people on wait lists, so that staging treatment. So if a patient is on a wait list and they're clear that they're most likely going to be candidates for treatment, they can at least start the process of harm reduction, and potentially preserve people's lives while they're waiting to get into more in-depth treatment with more in-depth counseling. So there are there'll be medication and urine drug screen monitoring and whatnot, and counting of the medication, but the more in-depth counseling and process of changing will come later on when they actually enter a program. There's also the Turning Point does some work with people who are early in recovery. They do a group Making Recovery Easier,
Right.
which is some of the recovery coaches run and introduce the concept of 12-step treatment and peer support recovery. And it's just an easy way to have a free recovery coach in the community to help and guide a person who maybe is struggling with addiction to stay safe. There are some in Burlington. I wish we had something similar closer by. There is a program called Safe Recovery that does offer needle exchange and some support services for people who are still actively using. That's, less maybe the people in the earliest recovery who are
Right.
maybe still really actively struggling, but it would be nice to have something like that, closer to this community. But
I mean, we're building our services,
Yes,
I
absolutely.
feel like, in Addison County. And I just want to mention that at the end of this show, we're going to have just from the Addiction Help VT website, we're going to have some of the resources that we list in the website for other counties, such
Great.
as Bennington County and Chittenden County. So what services does Bristol Internal Medicine provide for its patients that you're treating with medication-assisted treatment?
Well, we strive to provide medication, and really buprenorphine, it should be noted, is it is a medication. It is an opioid, but it's longer acting, so that people don't have cravings and they can lead a normal life. Basically, in certain respects, it is like a replacement of insulin deficiency in a person who's diabetic, a person is a very severe diabetic. So folks who have been using for years and years, 5, 10, 15 years, may have a lot more difficulty coming off totally at first. They may need to stay on a medication for a period of time. So we do offer a provision of the medication, not in the office. It's a prescription.
Right.
We don't have anything on the premises. But for folks who are dependent on opioids, they will take the buprenorphine and certainly feel normal. They won't feel anything really from it other than just, a sense of well-being, that they are not craving,
Right.
wanting to find street drugs. But then there are plenty of other services that we offer to help people change. So there is the stability. And that's an important part. The medication is important because, there have been studies that show that with, and I'm talking about folks with very severe addiction,
Right.
not people who may have made some mistakes and maybe they can just stop. I'm talking about people with multiple failed treatment attempts who have been using for years and cannot stop. And it's a difference between maybe they're going to end up dying or they need to be on a maintenance medication. So that it's an area of controversy for some, but in the evidence really shows that among those folks, that maintenance therapy works. It prolongs life. It enables people to raise children and hold down jobs. And so we also focus on that aspect of their lives. How can they be better parents? How can they find jobs? And we work actively hand in hand with the counseling services of Addison County. We have a counselor on site, Sean Thompson Snow, who's wonderful. And he works with folks individually and some folks on a group basis, meets with them at least monthly, sometimes weekly. Depending on where a person is in their treatment and their recovery, and people work on their relationships. They work on the sense of their self. They learn to come to terms with what they've done. But the most important thing is that they learn how to change their behaviors, change who they're hanging out with, so that they can make healthier decisions. We have a nurse case manager who actively works with patients as well on people developing healthier behaviors. We like to try to encourage contraception early in recovery,
Great.
because it's important people get healthier, and we want to try to help women take better care of themselves. We test people for HIV and hepatitis, for blood-borne infections from sharing needles, and if we find infection, just addressing that. And there are a lot more options in that regard now. So we work with someone at CSAC, Lonnie LaForest, who does jobs counseling and jobs training, works with people in the community to help people get jobs. So it's a comprehensive program, and we
Right.
really try to look at the whole person and not only what their needs are from a medication standpoint and a medical standpoint, but what do they need holistically? What can we do to help them develop new skills, new attitudes in life. So it's a real collaboration between medical professionals and people in the counseling profession.
It sounds amazing. It's huge wraparound services, and I love the idea of using this medication to help people feel well so that they can focus on not the craving, not the addiction, but raising their kids, having a job, and forming healthy relationships. That's what you just described. It's fantastic. So what's the biggest challenge for you as a provider of working with those who are struggling with opiate addiction? And conversely, what's the biggest reward for you, of working with folks who are focused on recovery?
Well, I would say some of the challenges, I would say that there are several challenges, and I think, probably personally would be when someone is not doing well, and it's uncommon that people relapse to opioids. I'll have to say we've treated, we have more than 80 patients. We've had prior patients. It's fractional the number who maybe have abused opioids, but sometimes people may relapse to other drugs, or they may engage in just unsafe behaviors, and it's not common. But if you get invested in caring for a person, it's sometimes hard if the person is not ready to pursue treatment at that time. If they really something sort of sweeps them back into that dark place, you want to do your best to try to rescue the person, but sometimes person has to be ready and willing, and there's only so much you can do. So I would say that probably is the most difficult thing for me personally.
Sure.
I'd say in general, the hardest part in terms of just the practical everyday nuts and bolts is dealing with some systems in place, for instance, when folks are trying to get, say, housing, and housing's very expensive, and they maybe are working at a job where they're not making enough money, or even conversely, Lonnie LaForest is really incredible for being able to place people, especially people who may have felony convictions, in jobs. It's not easy at all once someone has that kind of scarlet letter on their record.
Right.
So sometimes that that can be frustrating. That can be very difficult. There's a real lack of affordable housing in Addison County, and
Absolutely.
I know that people are trying to look at that and address that. But it's not a unique problem to this area. It's a problem where anywhere where it's desirable to live. So we do the best we can. And I'd say the biggest rewards really is watching some people really just blossom. They come out of, they really just open up and become who they really want to be.
Yep.
I've definitely seen it again and again with, people who discover certain skills and certain interests, and they are freer to enjoy them. But that's a pretty unbeatable thing to see is really basically, my first patient I did that with, I really saw the person really kind of close to the brink of death, I would say, and just the sense is that I basically pulled them from the breaches of death, and right now they're just a really full person with a full active life, and I'm really feel very privileged to help them get to that place.
That's a pretty incredible story and feeling as a provider. I imagine that when folks are really focused on their recovery, that you have a really nice relationship. You really have opportunities to build a relationship with your patients, and that when it works great, and it's very rewarding. How often do you or your staff check in with your patients that you're providing this treatment for?
Well, it depends. In the very beginning, we will see a person even up to 3 times a week, because when we are trying to find the correct dose of medication, we do some dose finding. We're observing for objective withdrawal symptoms. If person is not on the right dose of medication, if they're still using opioids, that may be an indication that the dose is not correct. We don't want to give too much medication, not because of, usually folks who are really severely dependent will not become too sedated, but we want to be responsible,
Right.
And just give the lowest effective dose.
Right.
So that can take a little bit of time and a little work. Usually within about 2 weeks, we're at the right spot. Generally speaking, can be longer, can be up to a month, and then ultimately we'll see a person weekly, and once we know that they're clean. Usually every 2 weeks, once we know that they're really getting productive in the community, usually either with work or school or volunteering, generally we will then have them go to once a month. So once a month is generally, with some exceptions, is what we generally tend to shoot for.
So your goal is to
check in once a month.
Yeah, build the relationship, make sure everybody's doing well, and then sort of phase out. That's a great goal to have, but you're still maintaining the relationship
Absolutely.
with them. And meanwhile, other folks in the office, such as you mentioned, your CSAC counselor, will still have regular contact.
Absolutely.
It sounds like a great system to really help somebody recover fully their lives.
Absolutely.
Yeah, great. So how, you've talked about how you're connected with the Counseling Service of Addison County, and you've mentioned the Turning Point of Addison County, and it sounds like you do some referring back and forth. How are you connected with Porter Hospital and this initiative?
Bristol Internal Medicine is a Porter-owned practice, and so we do get support from the hospital, and the Blueprint for Health is very important. So Susan Bruce is our liaison through the hospital and the state, the Department of Vermont Health Access. Okay. So that's our relationship there. I should say that we are working on continuing to foster relationships with other community agencies. So we do liaise with the Department of Children and Families and with Probation and Parole, trying to form, so sometimes when people are involved with those two groups, there might be, the recovery is a little bit higher stakes. So, but we're trying to form a positive relationship with them so that that recovery becomes more of a reward rather than, something that they need to avoid contact with these agencies, and that there's a lot of fear of punishment. So that can be a struggle for folks who are involved with those two agencies, but we're working to try to, I guess you would say, maybe soften those edges a little bit, and just have people focus on the positive, focus on recovery. So that's been, I would say more often than not, that's been the usual pattern, is that people are so focused on just getting their life back that it's not something that they have to fear their probation officer or anything like that. So
right. At the end of the day, their recovery means that they're less likely to have interaction with probation and parole.
Exactly.
So it sort of, it works itself out.
As long as they're focused on doing the right thing, which I'd say most people are, these things just sort of fall into place. They get parole, or they get more a little bit more interaction. They get partial custody or whatever arrangements are possible through DCF when the DCF workers know that they're no longer using drugs and they're trying to interact better with the families. Yep.
So talk a little bit, because I did say that our topic was medication-assisted treatment. So talk a little bit about, what does that involve? What are the medications? And, we talk about in Vermont a hub and spoke model. Can you talk a little bit about and explain that?
Yeah, so there are three main medications that we focus on, or that there are three main medications that are used in medication-assisted treatment, and this is specifically for opioids, and opioids are either prescription opiate pills like oxycodone, OxyContin, Vicodin, or hydrocodone. There's a number of prescription pain medications that unfortunately some people have fallen into addiction with too. And also heroin is the big one right now. So those are opiates. I will refer to it generally as opioids, since it kind of encompasses a larger class of them. And the medications we generally speak of, there are three, and two of them are basically replacement therapies. They are opioids, but they're longer acting, and I'll get into that in a moment. But the other one is naltrexone, and that is an opiate blocker, meaning that if a person is taking naltrexone, they'll be unable to get high from opioids.
Okay.
And that's an exciting medication in many respects. Number one, because it's not an opiate, but it's been around not as long. There's different formulations of it now that are very appealing, such as a once a month intramuscular injection, which gives people a lot of freedom from, they will just realize that if they can't get high, then it's not worth it.
Right.
But there are some potential issues with it. It's certainly not as tried and true at this point. There's less evidence to support its use. But for the right person, it's definitely a very good choice. We definitely have some people who are on naltrexone and doing very well.
Great.
So it person has to be very motivated. They have to be able to be abstinent from opiates for a short
Pretty
period of time
stable.
to even get on
right.
naltrexone. So maybe the more stable patients, maybe patients with less severe addiction. But it'll depend it'll vary from person to person. The hubs, we call it a hub and spoke model because there are some centralized addiction treatment centers where all they do is addiction. So for instance, the Chittenden Clinic in Burlington, Westridge, and Rutland. There are a couple others around the state where their main purpose, they treat people with methadone, which is the oldest medication that is used in medication-assisted treatment. It's a much stronger, more potent, and potentially dangerous medication if not used correctly. So people really need to be specially trained. Methadone is not used in doctors' offices to treat addiction. For that reason, the people need to be very skilled, and people need to be very closely monitored. And so that happens at a hub where people may come in for daily dosing for a time. And the hubs offer support for people. So if basically the hub, it's like, if you look at a wheel, the central part of the wheel, they offer the support to the surrounding spokes, these surrounding outlying community doctor's offices, so that if a person maybe is struggling with addiction and needs more help than, say, a primary care physician with maybe less training knows to offer, there's even more support and more wraparound services at these hubs. So it's a really good system that enables people to have more support if needed. It's basically almost as though it's like if a person gets sick and they go to Porter Hospital, but maybe they end up needing a heart catheterization, and then they need to go to University of Vermont. I'm not used to calling it that yet. Still calling it Fletcher Allen. For a heart catheterization, it's the same kind of thing where people might need to go for more specialized services. They also will treat some people with Suboxone there, but methadone is really, it's probably the medication that's been around the longest. And for some people, maybe with the most severe addictions, some of the people, not everyone with the most severe addictions, we don't fully understand why, Suboxone probably does work for most people, but there certainly are patients that do better on methadone. So it's kind of a little bit of a black box. There's probably some genetic factors and other factors, but most of the time when I've treated people with buprenorphine, which is, we sometimes call it Suboxone, it's the brand name. Most of the time people do pretty well on it. But that's a different medication than methadone, and it's a little bit easier to use. It has a slightly safer. The safety profile is a little bit better, especially with. There's less training involved in learning how to use it and how to dose people. So. And it's a slightly less potent medication. So, but it works pretty well. And again, the issue is these longer acting medications. They prevent people from going into cravings, and basically with heroin and some of these short acting medications that people have abused, become addicted to, they basically ride this roller coaster of it wearing off every 3 or 4 hours, and then they need to go seek out more. But with methadone and buprenorphine, we're talking about 20, 24, sometimes 36 hours of effect from a medication. So,
Dr. Glick, you are just a wealth of information, and I'm so sorry to say this, but we are out of time.
Really?
You did such a great job of explaining all of this. We really would encourage folks to go check out our website, addictionhelpvt.com. Thank you so much for your time today. You did a fabulous job of explaining a pretty complicated issue, and we'd love to have you back on the show again.
Yeah, that'd be great. Thank you so much for having me.
Thanks.